So today let's talk about empty follicles in IVF. So when you look at in vitro fertilization, the aim is to produce follicles and which will contain mature oocytes. However, all follicles do not yield an egg, and when they do not yield an egg, it's called an empty follicle. This can vary in proportions and may lead to empty follicle syndrome, a rare condition where no oocytes are obtained despite adequate development of follicles. Understanding why this occurs, again, is an important stage. So what are the causes of empty follicles? You could classify into 4 reasons, and one is technical, and it's called a false empty follicle syndrome. Often results from errors of giving HCG injections, such as incorrect timing, incomplete dose, or being exposed to very high temperatures, which happens during summer generally. And these technical issues tend to lead to getting less eggs. Very rarely you use a very low aspirate pressure, which is again a rare thing which can contribute. The genetic factors, and this is genuine empty follicle syndrome, which may be linked to genetic mutations such as those of LHCGR gene or zona pellucida genes. And these are rare, affecting follicular development. They seem to occur probably around chromosome 2, and these are one of the causes of poor ovarian reserve. Again, finding this out is quite difficult, and often we do not go there. But what is the commonest reasons where we find it? You would find them in ovarian aging and reserve. And as women go over 40, there's a significant risk that a larger number of follicles will start showing being empty, and increased pro-apoptotic gene expression in other cells and ovarian resistance to HCG can lead to empty follicles. But it's again age and AMH, or very low AMH, that form the key. Now, if you look at hormonal imbalances such as a poor stimulation, discordant follicles, follicles that do not grow adequately, improper medication doses, and hormonal imbalances can result in follicles that do not contain any mature eggs. So what would we consider to be the commonest reason? The commonest reason tends to be ovarian aging and reserve. And this is what we would end up seeing. This is what we are more commonly going to see. So what is the ratio of empty follicles? The proportion of empty follicles in a typical IVF cycle is not universally standardized and varies from individuals, from age and ovarian reserve. Research indicates that it is common for number of retrieved eggs to be lower than the number of follicles, and some follicles are naturally do not contain any eggs. Now, the specific query is, are 30% of follicles empty? But that's entirely not certain. The percentage of empty follicles tends to rise, and that again rises with age. On an average, we think about 30% may be empty. But whenever it reaches 100%, it is more likely to show that there is a problem. Now, age continues to be a critical factor, and its impact is quite huge. So research shows that the importance of, or the incidence of, empty follicle syndrome increases with age, particularly after 40 years of age. One study found that it was 6.3% in women over 40 compared to 1.8% in women who were younger. So recurrent empty follicle syndrome rates are also higher in the older age group, with 24% in the 35 to 39 years of age and 57% over 40. So clearly there is good evidence that age also increases the number of follicles that are empty. From the age to 35 to 40, a proportion of empty follicles increases due to natural aging of the ovaries, and specific proportion of each age group is not detailed in literature, and we do not know that. If you look at the role of AMH and FSH, two markers of ovarian reserve, the AMH and the follicle stimulating hormone are key indicators of ovarian reserve. A low AMH suggests a diminished ovarian reserve and can lead to fewer number of follicles and a higher number of empty follicles. On the other hand, the high FSH is often seen in older women and maybe is another sign that the ovaries are coming under strain, and it correlates with an increased empty follicle rates. Studies have shown that women with low AMH and a high FSH have a poorer IVF outcomes, including a higher rate of getting empty follicles. Now, over a period of time, we have seen the effect of dual triggers. The use of dual triggers, which is combining HCG and GnRH agonist, aims to improve oocyte maturation. Now, even with this, you don't address the primary cause of age, or low AMH, but you can address the cause of HCG failure. And if you see what is its risk of HCG failure, it seems to be between 1 and 2%. And what's the risk of having a GnRH analog figure? It's about 2 to 3%. This suggests that intrinsic factors such as genetic predisposition, ovarian resistance may override the benefits of dual triggers. So let's look at the normal versus abnormal. In normal, it is normal for some follicles to be empty. So if you say, oh, with all follicles contain eggs, that's rare again. If you think between 20 and 30% of follicles in a younger women are empty, and not all may contain mature egg. This is a natural variability. Abnormal, and when you see empty follicle syndrome, when no eggs or no oocytes are obtained, is abnormal and rare, with a general incidence of 0.5 to 7%. Again, it goes beyond 5% over the age of 40. High proportion of empty follicles, especially approaching the empty follicle range, may indicate an abnormal issue. So it seems that 30% may be within the normal range given the normal occurrence of some follicles, but this is likely to vary. Possible solutions: change the stimulation protocol, tailor it, help to maximize follicle output, more follicles, better chance of getting more eggs. Sometimes a gentle protocol to allow for a better growth of follicles rather than a faster growth of follicles. Again, sometimes you end up seeing follicles grow super fast in about 8 or 9 days. And in those cases, again, you will see a large number of empty follicles. Using both HCG and GnRH agonist, when it repeats, egg donation is one option. And then genetic testing, this again is difficult because it's very difficult to find out which exact gene may be responsible. So let's summarize. Age, empty follicle syndrome increases with age, over the age of 40. AMH again, low AMH is linked to higher number of empty follicles, and it shows you the impact of ovarian reserve decline. FSH, again, a high FSH is associated with aging, and again will show more empty follicles, and it reflects the aging process. Dual triggers may help, but it doesn't prevent genuine empty follicle syndrome. Effectiveness varies, and genetic factors are not treated. Technical factors, again, such as improper administration, improper doses, those can be changed. Genetic factors, again, mutations in the LHCGR gene are linked to poor response. In conclusion, we would say empty follicles are a common occurrence, let's say about 30%. Empty follicle syndrome is abnormal and requires careful management. You have, indicators that will tell you may hit the empty follicle levels, and those are advancing age, low AMH, and high FSH. On the other hand, you could see fewer number of follicles. Again, that is another risk. This analysis underscores the complexity of IVF and the need for personalized approach, and thinking of what is the best option needs to be considered. So again, this is a short talk on empty follicle syndrome, something we see very often in terms of empty follicles, and finding out a difference between empty follicle syndrome.